Okay, hello, good morning everyone. Here, me with Karen Peters from UNODC in Bangkok Regionals. Perhaps you can introduce yourself to our audience.
Oh, sure. Hi, everyone. I'm Karen Peters. I work for UNODC. I'm the Regional Drugs and Health Program Officer, and I support the work of the agency within Southeast Asia and the Pacific.
What does UNODC stand for?
Oh, good question. It's the United Nations Office on Drugs and Crime.
Oh, drugs and crime. So it's a bit scary sometimes when we listen about drugs and crime. So, why UNODC are so concerned about this?
Oh, thanks for asking that question, Sam. UNODC, and in fact, it's not just UNODC, there are 12 other UN agencies. They started this advocacy around compulsory treatment in 2012. And we started with releasing a statement that's asking countries to please consider closing these compulsory centers. They have huge concerns, mostly around different areas. Okay, the first one being human rights considerations. Let me take you back a little bit to why this is a human rights issue. When we understand drug dependence, we use the WHO classification and definition of drug dependence. And drug dependence is considered a multifactorial chronic disease. Okay, so we've put it in the category or classification of a chronic illness. Okay, for treatment of chronic illnesses, all of them, for example, diabetes being one, we ensure, and we'd like to ensure, that a patient's informed consent is obtained to undergo treatment. So, for example, if your parent is diagnosed with diabetes and they go to the clinic, the doctor will have a conversation with them and say, you need to ensure some lifestyle changes, okay, in order to control your diabetes, your blood sugar levels, and you might need to also go on medication. And here's the medication that we are prescribing, and here are the lifestyle changes that we recommend. And the person decides whether they will start the medication, and they also decide, of course, if they will start to change their lifestyle, right? If they do not change their lifestyle, they have consequences. And if we look at drug dependence or people that have problematic drug use, we are encouraging governments to have the same approach. Okay, have a conversation with the client. This is the problem, right? There's clearly a health risk here related to your substance dependence. This is the medication we are proposing. This is the treatment plan that we are also offering. Would you like to consider going down this path of treatment? Unfortunately, this is not the approach that many governments take when it comes to dealing with people who use drugs and people who might have a drug use disorder. The approach is you have to stop taking drugs or else. And a lot of the treatment that is provided in many of the countries throughout Southeast Asia is based on this, is based on abstinence. So they want people to stop taking drugs as a mandatory measure. And there are no other treatment options available for the clients. So from the public health perspective, from a human rights perspective, we're saying that this is ineffective. It's a violation of the patient's rights. We have to give people options and give them the choice of deciding whether they will engage in drug dependence treatment or whether they are not interested in engaging in drug dependence treatment at this time.
Interesting. So, beside the violations of human rights,
Yes.
is there any other things that you can let us understand a little bit more
Sure.
about why we need to pay more attention and consider this?
Thank you. Unfortunately, compulsory treatment or residential inpatient rehabilitation is also seen as the primary, mode for assisting people who use drugs. Okay. This is, again, if we look at the nature of substance dependence and the nature of the problem of drug use in the society, we can accurately understand that the vast majority of people that are recorded as using drugs might not even need a treatment intervention.
Hmm.
Okay, so we consider them non-dependent drug users.
Yeah.
Okay, which means that they use drugs for different reasons, for different purposes, but they're not dependent, which means they do not have the disease of drug dependence. Okay, so they don't have a drug use disorder. In this instance, treatment for somebody that doesn't have the disease would be ineffective.
Yeah.
Okay. What does that mean for the average person? What does it mean for the government? It means that budgeting, the response to the drug concerns need to be tailored towards the need of the client or the drug user or the patient, whichever terminology you prefer to use. Okay, how to understand what do they need? Okay, if I'm not dependent on drugs and you put me in a drug treatment facility, you're wasting your money because you have to feed me, you have to house me, and you have to have medical staff and probably custodial staff to keep me there. Okay. So we're saying, please stop wasting your resources. There are more effective ways for you to help those persons that are not dependent. They could be offered services at the outpatient level, at the community level, or within different service sites, you know, within the network or the community of where they can access. And they don't need to be intensive. They might need to engage in treatment, or they might decide that they're not interested in engaging in treatment, in which case we promote, as the UN, what we call harm reduction strategies or harm minimization strategies. And these strategies basically are saying, okay, if you're not ready to stop using, okay, please make sure that you're going to be using drugs safely so that you're not spreading illnesses, which could, or you're not contracting illnesses, which could basically have a more harmful social consequences. For example, if a person contracts HIV through sharing of needles and syringes with somebody else who's HIV positive, they have to be on antiretroviral therapy for the rest of their life. At this point, we don't have yet a cure for HIV virus. So we're saying the systems, the health systems, the care systems need to be responsive to what the needs of the client are. And that might not be treatment, which is in the formal sense of, a therapy that would help with a disease they probably do not have. The old estimates used to be that about 1 in 10 persons might develop a drug use disorder. Okay, so if we look at the total number of estimated people who use drugs in any given country, about 10% might need to undergo some form of residential inpatient treatment. The other 90% could, if the resources were allocated adequately and the services available that would suit their needs, just be offered interventions at an outpatient level in the community.
Interesting. So, in terms of to make that happen, what are the things need to be done, or what are supporting factors or steps that need to be taken?
Yeah. In 2015, we had the UN organized a regional consultation that was where we brought together various governments throughout Southeast Asia and East Asia to talk about how they could transition from compulsory treatment to what we call voluntary, community-based, evidence-based treatment and care services, right? Because it's not just treatment, it's services for people who would be using drugs. And during this consultation, the experts at that time identified 3 key factors that need to be in place in order for a transition to happen, in order for countries to move from point A to point B. The first is that they have to have a legal and enabling policy environment, which means they need to possibly relook at the laws that are ensuring that people have to go for drug treatment if they are caught with drugs or they are caught engaging in drug use. So this is a very key factor. So the legal and enabling policy environment needs to be in place. The other reason the legal and enabling environment for the laws and policies has to be there is because they perpetuate the stigma and the discrimination that people who use drugs face. If the law says drug use is bad, you're a criminal, then the health response, the community response, is going to view drug users, people who use drugs, as criminals. And again, this is something we are trying to change. We're trying to change the understanding of dependence, because we can see, and we have seen, the models that are in place don't work. So the legal and policy environment needs to be there. The second part is around the systems and the health services that need to be strengthened. If we are saying people don't, or they shouldn't go into residential treatment facilities, there needs to be an alternative that's available for them at the community. And unfortunately, the community healthcare services in many countries, right, not just Indonesia, are not yet geared towards offering outpatient services for people who use drugs, right? They are also, there's other concerns around the community health systems, which we're not criticizing, because, to be honest, we understand that within a country that's developing, it's not easy to provide all of the services that an individual might need. And we do understand that the community, the local district health services, are quite overloaded with the burden of other illnesses, hypertension, diabetes, HIV/AIDS, right? So to add on addiction treatments or care services would probably just add a burden to them. So we're saying, if that's not in place from a government service center, then we need to have civil society organizations that are offering the service. But the services have to be there, or else people are going to be diverted from compulsory treatment, and they might not have anywhere to go if they are experiencing the adverse consequences of their drug use. Okay, so that's what we're saying. In the second broad area is supporting the health systems strengthening. The third area is financing. This is a big one, right? In every health response, there needs to be money that's going towards that. There's been several studies that have done what we call a cost-benefit analysis. Okay, they surveyed people that had gone through compulsory treatment and people that had accessed community-based treatment and care services. They did a comparison of the cost of having people in residential facilities versus community-based outpatient services. And they established that there is at least a 5-fold, sometimes 7-fold saving from the government investment if they were to just allow people to access the services at an outpatient setting. So it's way cheaper allowing people to go stay at their homes, come in for services that they need, and return to their homes, instead of keeping them in a facility for an undetermined period of time. Not just is it cheaper, they also did the benefits, right? The benefit part of it was, when people had come out of compulsory treatment centers, they returned to drug use, almost about 70 to 80% of them within 3 months of being released from a compulsory facility. However, people that were accessing voluntarily treatment and outpatient setting, their treatment adherence lasted at least over 1 year. And the what do we call it? We don't say recidivism, because we are promoting a non-criminalizing sort of language when it comes to drug use. But the relapse rate, so the rate at which they return to drug use, was much lower than those that had been forced into abstinence-based or treatment programs that were in a compulsory facility. So it's also a logical financial investment to invest and divert money from residential facilities to community-based outpatient services. And where it comes to financial investment, we are asking the ministries of home affairs, the drug control agencies that usually have the budget for treatment services, to consider reinvesting it in modalities which are low threshold and more accessible at an outpatient setting.
It is interesting to see and listen from you about the facts, about the numbers that people, retentions, and also the number who are actually accessing the benefits from the services. I think we can learn from it, and we can try to adopt that within our countries. Last question is, What is UNODC role at this point, and what kind of supports, maybe if you willing to provide that for each country, especially Indonesia?
Yeah. Thanks, that's a great question. UNODC provides a lot of technical assistance. So we help governments to analyze their drug treatment systems and to redesign, if they so choose, the services that would better suit the needs of the clientele that they are trying to reach. Okay, so it might be technical assistance along the lines of what I've been describing. How can they refinance their drug treatment services? It might be expertise, right, in relation to what is needed from a health systems component. Or, for example, our role is also as a connector. So one of the really important components of the work that we're doing is supporting academics, practitioners, and clinicians at the country level to also advocate for changes like this. We have put together an expert advisory group on compulsory treatment, and this consists of representatives from countries across East and Southeast Asia, and they are really the leaders in the field when it comes to topics around drug treatment or alternatives to compulsory treatment. And so we have supported the establishment of this group. They advise the UN on how we can better do this work, the work that we are doing in supporting governments, and they also serve as focal points in country. So for example, if Indonesia comes to us and says, look, we would like to really ramp up our transition from compulsory treatment to voluntary community-based treatment services, what can UNODC help with? We will bring on these experts to be advisors to the government, including ourselves, and we all work together in order to ensure that, you know, the relevant steps and actions are taken. So yeah, essentially UNODC offers technical support where it is possible, and when the finances do permit, we do help the government to organize meetings and, you know, help in that type of sort of with that type of financial support. But as an agency, we are kind of specialized and pretty small in comparison to the other UN agencies, which means our expertise lies in really understanding the needs within the drug system and how that governments can respond to those needs from a technical perspective and a technical level.
Thank you for that information. I think this is really valuable for all of us about the role and about the things that we can consider actually to improve the services. Last questions. You're talking about the governments providing support.
Yes.
Does UNODC support community?
Of course. We do support the communities. We help the networks of people who use drugs in different ways, depending on what the request that we receive. So we do support them in various capacities. A lot of the trainings that UNODC offer in the region are geared towards strengthening the capacity of the communities and also helping us define what is the communities, right? Quite often, you know, we understand people who use drugs as a static group of individuals, right? This, unfortunately, is, or fortunately, actually, is not the reality, okay? We're looking at this, I'll give you an example from the HIV response. In order to tackle the HIV prevalence amongst key affected populations, certain groups were identified. People who inject drugs, sex workers, men who have sex with men, as examples. We are seeing now that the HIV epidemic is not only limited to these traditional groups. We might have less people injecting drugs than we did 10 years ago, but the HIV risk still exists amongst people who use drugs in general. And who uses drugs, right? Literally every component of a society men who have sex with men, female sex workers, heterosexual men that have sex with women. You know, these groups of individuals are not static and they're not uniform. And so in that response, we also need to understand when we say communities, we support people who need access to services for treatment. And that can be, you know, people who inject drugs, or it can be men who have sex with men. So our support now is centered around the needs. Okay, we see a lot of stimulant drug use, for example, in the region, and so one of the training packages we are training communities on right now is how to prevent HIV for people who are using stimulant drugs, and not just HIV but other communicable illnesses. For example, you know, spreading hepatitis C through skin-to-skin contact, or you know, through wounds that might not be, you know, blood related. So that also includes promoting the use of safe smoking commodities. So these are the type of interventions we try to walk the talk, although it's not always possible, in when we are offering programs, to see what does the community need and then offer the support that way, instead of coming with our agenda of what we want to strengthen and then, you know, only focusing on that in that component. So we do welcome linkages with the different organizations that are focused on the drug issue. We don't only work, by the way, on treatment and harm reduction, we also work on drug use prevention, and I think that's a really critical part of this whole cycle. We can't forget that we still do want to avert the start of drug use amongst young people. And this is definitely an essential area that we have to focus on along with the other components of the work.
Well, thank you for that information. So I think we can conclude that non-government organizations can knocking on your door, seeking for your
Absolutely.
support. Yeah. And thank you for your time. I think this has been a really precious information that we can digest, and we can put plan on that. Just keep your door open for us. We
Sure.
might knocking on your door. Thank you
Great.
very much.
Thank you very much. Thank you.